So we all know that the mitral valve complex and the apparatus is very complicated. There are a broad spectrum of mitral valve therapies and increasing complexities for percutaneous technologies. And you can see here the considerations for therapies are quite vast. If you look in this table, you can see anatomic structures on the left and just some of the important aspects that we think about for each of these anatomic structures. And I don't think you can come up with nearly a quarter of this in the aortic valve pathology. Development and implementation clearly of mitral valve therapies has lagged behind the aortic therapies over the last 15 years. We only have one FDA-approved device, the MitraClip, and we all know that this is a more complicated field, a complicated apparatus, interplay with the left ventricle, and a lot of different pathologies, whether we consider it primary or secondary MR. But I think the biggest issue is our lack of imaging over the last 15 years. Even since the introduction of 3D echo, really, we haven't come a long way. So where are we now? Well, we have 3D 4D echo. We can see mitral valve leaflets here, failed mitral bioprosthesis, catheters, wires, and even devices. On the right, you can see a 4D reconstruction of a CTA, where you can really see detailed anatomic information, important spatial relationships of other cardiac structures, and now we can start to begin to figure out how we can navigate large equipment. So what are some of the therapies for percutaneous mitral valve technologies? Well, it's the interaction with the mitral apparatus. On the left, a lot of the mitral valve is fluoroscopically silent, and we really need to understand exactly where to implant a lot of this technology. Using fusion imaging, you can identify this as a valve-in-valve prosthesis or valve-in-valve case where you can't see the bioprosthetic valve, but using fusion imaging, you can actually help to guide the prosthesis. What other things do we consider? Well, relationship to the LVOT. This is a case that we did valve-in-Mac back in 2013. We really weren't considering LVOT obstruction, but you can see after implantation in this patient, we had significant obstruction. What are some of the other challenges? Well, relationships of the coronary sinus and circumflex artery, and do we really want to be putting wires in the coronary sinus or in the left circumflex artery? And is that really a true representation of where the mitral apparatus is, or the mitral annulus? We need to know sizing and how that interplays with the aortic valve and the outflow, and we need to know implantation angles. In addition, we need to have patient-specific, site-specific access. We need to have perfect transseptal puncture, and then transapical access for a lot of our transcatheter mitral replacement technologies that are in direct line with the mitral valve, away from the LAD, away from the true apex, and away from the lung. So what are some of the limitations of fluoroscopy? Well, fluoroscopy lacks, as we know, characterization of non-radiopaque structures, and it provides only 2D projections. And this is just one example of a mitral paravalvular closure where this was performed via a retrograde approach. And you can see here, we think we're around that mechanical mitral prosthesis, but if you look in a different projection, we're back out the aortic valve down a bypass graft. So understanding that fluoroscopy is not the main modality for therapy for this field. Interventional imaging, we do have limitations. These are just some of the list, but we realize that no single imaging modality provides us all the necessary information. And with increasing complexity of these new procedures, some we've seen today, combination of different modalities is absolutely needed. So where have we come in our interventional suite? Well, we can now take CT and MR, merge it with X-ray to get CT or MR fluorofusion imaging pre-procedure, and we can merge the echo with the X-ray to get echo fluorofusion imaging. All with the goal to increase diagnostic accuracy by combining anatomical, morphological, and functional information for us, the interventionalists, or the surgeons within the catheterization laboratory. So what does it look like for CT fluorofusion? Well, you can segment out on the pre-procedural CAT scan any chamber of the heart or any extracardiac structure. This is an example for mitral valve-in-valve, where we're able to segment out the left atrium in yellow, left atrial appendage, left ventricle, you'll see in blue, mitral bioprosthesis, and then determine best therapeutic options. Landmarks here, we're able to pinpoint our access, in this case transseptal. And what you can do in double oblique projections, choose your transseptal puncture. In this case, posterior and inferior that gives us best line of action to that mitral prosthesis. What about virtual planning? We're doing this now with the Segmentation system. You can do this with the Fusion software, where you can choose a valve, choose the valve size, and then actually choose the valve depth to determine what does this valve interact with. We do this with Segmentation to understand what our neo-LVOT would be for valve and valve implantation, and now there are similar simulation models even for cardioband as we screw in these direct annuloplasty screws into the mitral annulus and its potential injury to the circumflex and coronary sinus. Well, optimal angle is also an issue with the mitral valve. It's not like TAVR and getting our line of perpendicularity. There are the optimal angulations that we need to achieve, and we can use the CT to help guide us. We need our coaxial and perpendicular planes to target structures, and we need, using the CT scans, to choose radiopaque landmarks for a radiolucent structure, just like the mitral valve. So choosing CR and positioning is quite important. And this is just one example, looking at a bioprosthetic valve and seeing how we can rotate the image and choose our best line of action for a mitral procedure. So how does a procedure look using CT-Fluoro guidance? Choosing our transseptal access, we're able to, you can see the left atrium in yellow, gaining access across the mitral prosthesis. And as you'll see in a minute, we're able to segment out the mitral valve prosthesis to help position the valve. Now here's a case where you can actually see the mitral valve, but in scenarios where the mitral valve is silent and this is a native valve, this is where this technology may become useful. Well, the same can be done for echo. And if you can merge the echo image using the face plates of the echo probe and merge this with X-ray. We've seen a lot of the valve technologies with echo, as you can see here on the bottom left, that can actually simulate the mitral valve, can actually determine the greatest areas for mitral regurgitation, and can actually segment out completely from anterior A1, P2, different segments of the mitral leaflets. As you can see here on the right, for mitral clip implantation, you can choose your best access point for transseptal. You can landmark the annular plane, as you can see here in the circle, and you can landmark your best placement for mitral clip to direct the mitral delivery system. In addition, you can actually, with this technology, with EchoNav, you can actually overlay the echo image directly onto fluoroscopy, so the imager or the interventionalist is looking at one screen. What does this look like for transapical access? As you can see here, you can landmark our skin access site, our epicardial access, in direct line with the mitral valve. So as we move forward to understand how to apply these transcatheter replacement technologies, you can actually choose your best line of access for the patient. And with the single needle guidance with the Siemens system, you can actually use a laser to detect exactly where you need to be on the skin surface. That will go directly into the heart. And we've determined that with this technology, with a 5 millimeter accuracy, can provide you that level of comfort. Our post-processing tools now are capable of segmenting and landmarking and placing devices, and we can take this same post-processing software and import it directly into our workstations, overlay it with X-ray, and use this for our interventions. So just to conclude, multimodality imaging is key for transcatheter mitral valve technologies. Merging technologies to improve imaging information is important now more than ever. Fusion imaging aids in planning and guidance for transcatheter replacement technologies, and it does help bridge the gaps in knowledge until innovation progresses these technologies to become safer, easier to deploy, and more effective. But really the need for image integration, or what we call augmented reality, is here and is important now more than ever as we really try to tackle this space. So thank you very much.